In this presentation, I will present on the pre-sigmoid and a combined approach. Uh, this procedure, as you know, will be utilized for especially the tumors which are there either only in the posterior fossa, extending into the middle fossa, or the tumor is there both in the middle fossa as well as the posterior fossa, but extends in front of the cerebellum, going towards the midbrain, not only the pons, extending up to the midbrain and towards the cavernous sinus. So where sometime you had to take out the tent has to be cut in to expose both middle fossa and the posterior fossa so that the tumor can be completely removed. And this is one of the very challenging procedures in neurosurgery, purely because of the number of cranial nerves and the vessels, especially supracerebellar, ICA, middle cerebral, sorry, not the middle cerebral, the ICA, supracerebellar, as well as the PCA blood vessels, which are in and around the midbrain, has to be tackled to take out the tumor very much without causing either the sixth nerve or the third nerve palsy. So I will tell you all the points which are required for the cadaver workshop in this, and then I'll take you down to the cadaver lab to show the exact procedure, how you had to do it. So there are three types. It's just an extension of the same procedure, but I can't call you the types. First is the retrolabyrinthine, where we'll expose the labyrinth, the semicircular canals, and you go pre-sigmoid to take out the tumor, in case where you don't want to sacrifice the labyrinth and preserve the hearing. And sometime the labyrinth we remove to expose the seventh nerve, but we preserve the seventh nerve, mobilize the seventh nerve, and take out the tumors. And in some patients, we had to take out the complete cochlea as well as the petrous apex to make sure the whole middle fossa and the temporal middle fossa will be together, posterior fossa and middle fossa together to take out the tumor completely, especially in a meningioma, chordoma, and such patients which has fossa extension tumors. So this is what is the pictorial depiction of these three procedures which I was showing you. So in a retrolabyrinthine approach, we take out the mastoid area, all the air cells, the mastoid, the antrum, and we just preserve the semicircular canal and take out all the bone which is in front of it, so that the sigmoid sinus is also pushed superiorly and posteriorly, and we open the dura anterior to the sigmoid sinus so that we will approach the cerebellum anteriorly and also come up to the pons region up to the fifth nerve very easily with this approach. From fifth nerve to the 11th nerve up to the foramen magnum can be exposed with this retrolabyrinthal approach. But in case where you want to extend to the middle fossa, sometime we have to take out the translabyrinthine, and in a combined approach, when you come either from the middle fossa area and combine with the posterior, you have to take out the translabyrinthal approach. And whenever the tumor extends towards the apex of the petrous bone or the tentorial hiatus, where the midbrain and the middle fossa comes together along with the third nerve area and the fourth nerve area, we had to do a complete transcochlear approach, which is rarely necessary, especially when we use only Kawase approach. Sometimes we can take out these kind of the tumors. So like any other approach, when we are doing, the positioning is very, very important. Dropping the vertex down, and turning the patient's head to the completely laterally along with the neuromonitoring, is very, very essential in these patients. The simple pre-sigmoid approach, you can just put the skin incision just below the tip of the mastoid along the jugular entering into the neck area. You can go up to the neck area when you want to expose the more of the sigmoid sinus, and up to the tragus, upper end of the tragus towards the mid fossa. So if you want, you can convert it into the middle fossa area. For example, in this picture I'm showing you where I'm doing the combined approach to the patient, where I've extended, from the tragus in the middle of the zygoma, I've extended about 3 to 4 centimeter above, turn around the tragus, extend up to the foramen magnum laterally. So this approach gives, this incision gives approach to both posterior fossa as well as the middle fossa in this patient. And very, very important that the combined approach, makes enormous difference to patients when you have, mid fossa and posterior fossa tumors extending each other so that you can remove completely. So what is very, very important, before drilling this area is knowing the anatomy. The external auditory meatus you have to identify, a root of the zygoma, external occipital protuberance, and a supramastoid crest. Now, what normally I do is before draping the patient, we tie, make sure some of the stitches are put over the external auditory meatus. We close the external auditory meatus, as well as the pinna can be brought in together with the skin stitches in front of the zygoma, so that the whole area get exposed very, very easily, and the external auditory meatus will not get ruptured because of the tension. So in this, you can see what is important is the squamous suture of the temporal region, mastoid, supramastoid crest, lambdoid suture maintaining. This we call asterion, which is the occipitomastoid suture, the lambdoid suture, as well as the squamous central suture. All three meet. This asterion is a key. Asterion, spinal of Henle, which is at the external auditory meatus, temporal, the mastoid tip is the triangle within that part we'll be doing this mastoidectomy in this region. So once again, I'll repeat: spina of Henle anteriorly, tip of the mastoid inferiorly, and the asterion posteriorly and inferiorly is the triangle with which we are going to do the mastoid drilling to enter into the pre-sigmoid approach, as well as deskeletizing the sigmoid sinus. So as I mentioned once again, this triangle you can clearly see here, the asterion posteriorly, the spine of Henle here, mastoid tip. This is the triangle within which we are going to operate, in these patients. So once again, we make a first triangular opening using the 6 mm burr, go from the asterion towards the spine of Henle and into the tip of the mastoid. This part, once you enter, you can clearly take out every part of the mastoid, so that you deskeletize the sigmoid sinus very easily. So you can clearly make out here, posteriorly I deskeletize here is the sigmoid sinus, the facial nerve, the mastoid tip, which I'll come again once again as we drill. So once we start drilling, you see the mastoid air cells, and be careful about the facial nerve at every point. Using the sigmoid sinus and the facial nerve are the key in this region when you are drilling. We call what is using the 6 mm burr, using like a paintbrush over the sigmoid sinus will not take away the periosteum over the sigmoid sinus. So that thin layer of the bone is left, so that there not be injury to that at all. So in this patient, you can clearly see here, I have drilled out everything. And once I drill, you can clearly make out the sigmoid sinus entering into the jugular bulb. And this is the mastoid tip area, the mastoid recess we call here, and the jugular recess. Here, the extra bone cells will be there. You have to use the 2 mm burr, and suprasemicircular canal, the posterior semicircular canal, as well as the lateral semicircular canal should be identified. And anterior to the lateral semicircular canal will be the incus, and inferior to the lateral semicircular canal will be the facial nerve. So identify the facial nerve at 2 points are very, very important. The inferior to the lateral semicircular canal, as well as the anterior part of the mastoid region, and at the anterior part of the jugular, the recess is very, very important. Otherwise, you will injure that very much. So this is how it looks, the triangle. And this is what we call sinodural angle, where the middle fossa dura, the posterior fossa dura, this is the sigmoid sinus. And this triangle is called sinodural angle. In this sinodural angle, the posterior part will have a thicker bone, which will extend along. Then as soon as you remove this, you will find the superior petrosal sinus joining the sigmoid junction. And this area is very, very important. A thick bone, you will find the extending this, the bony drilling with thin layers, which is strokes are done from anterior to posterior, thin layers exposing the tegment tympani in this area, and the sinodural angle is the key in the pre-sigmoid approach. And as you come down, just behind the posterior semicircular funnel, you will find endolymphatic duct. This endolymphatic duct you should never rupture, because sometimes the CSF leak will also happens, and as well as the hearing impairment happens. But identifying under microscope is the key in these patients. So once you do this, and this part of the dura is exposed, once you expose this, you'll clearly see, as I mentioned you earlier, you can expose from fifth nerve. Sixth nerve will go superiorly. You will not come into that junction. ICA, as well as seventh and eighth nerve, and lower cranial can be exposed very easily with this pre-sigmoid approach. And the posteriorly, you will have a thinned out bone will be left over the sigmoid sinus, and you will be working any tumor which is anterior to the brainstem in the anterior to pons and medulla and over the clivus can be removed easily by identifying as at the same time these securing your blood vessels, securing without injury to the cranial nerves, can be done with this approach. Though it's a narrow angle, but sometimes table turning, and suckable tumor can be done very, very easily. So in a combined approach, what do we do? In a combined approach, what is important is, where we expose the middle fossa, posterior fossa, transverse sinus is exposed, and the mastoid is exposed, exactly what I shown you. Most of the mastoid, when I drill nowadays for the cosmetic purpose, I do cosmetic mastoidic bone flap is removed, where you use the 2 mm burr first, then take the osteotome or the bone cutters. You can take it out at the end after placing the bone, the fat tissue into the mastoid area. You can cover this so that the bone surface is maintained and patient will not have cosmetic depression in that region. So you can clearly see in this picture, in addition to the pre-sigmoid approach, which I showed you, which is exposure is only this much, we are exposed the middle fossa by extending the craniotomy. So in this approach, how do we do it? Important is, where do you make the craniotomy? There are 4 burrows we make. First is the burrow number, is in the asterion. The second one is the temporal region. And the third one is the one which is classically we do for the trigeminal neuralgia exposure, the junction between behind the sigmoid sinus as well as the transverse sinus. That's the third, the burrow we do it. And the fourth one at the bottom of the temporal region for the tegment tympani. So here in the front, we will expose the middle fossa base, and you have to make sure the geniculate ganglion is identified. The facial nerve has to be stimulated in this region whenever you're lifting the temporal bone. And after making the burrow, the important is 2 cuts you have to make using the 2 mm burr. That is, one is at the bottom of the curvature of the posterior fossa, and in front over the sigmoid sinus for the craniotomy, and at the turning of the middle fossa in the temporal region anterior to this. These are the small burrs. If you create, the whole flap can be removed as a single piece. So the rest of the things is like that. The inferior pre-sigmoid approach, what you have done, you continue to do that. And in the middle fossa, go to the V2, V3 region, expose the foramina of rotundum, foramina of Bowell, take out the middle meningeal artery from the spinosum region. And once you do that, the whole exposure from the sigmoid sinus at the jugular foramen up to the V2, you can completely expose along with at the sinodural angle, as I'm mentioning, is the superior petrosal vein, can be exposed. So opening the dura from in the posterior fossa separately, middle fossa separately, and coagulating and clipping the superior petrosal sinus gives the entire exposure from The third nerve, if you want to expose even the optic nerve, the chiasm, if you extend this incision towards the base of the middle fossa towards the frontal region, you can expose the whole area from the third to 11th nerve can be exposed with this approach. And as you go in, you can cut the hiatus of the tent with preserving the fourth nerve. So